Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health, reporting for the week of February 17th, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. In today's briefing, I'll provide an update on the respiratory viruses, as well as measles, and talk about our data challenges as it relates to flu. So first, starting off with the respiratory viruses, weekly percent positive, we can see here that flu, represented by that bright blue line, continues to make up by far the largest share of the respiratory illnesses that are being tested for. And this is showing us through February 8th. And if you look at the guide all the way to the left of the graph there, you can see that influenza cases are making up over 30% of the viruses being detected currently. Nothing else is really coming close to this. The regular cold viruses are next in that gray line at just over 11%. But remember, this does not include home tests. This is going to be tests in a care setting where people are actually getting tested, like the hospital or emergency department. So people who are sick enough to be there, or in the outpatient setting to a lesser extent. So this would be for people who go because they're sick to their doctor, but maybe didn't take a COVID test or don't know what it is that they have. So if you've already taken a COVID test, it's unlikely that you're going to show up to one of these settings unless you're really sick. So this is all relative. We're going to need to take this in the context of the other indicators that we're looking at, like emergency department visits. So taking a look at emergency department visits, it looks like flu emergency department visits may be ticking back down since reaching that last little peak that we can see there on February 1st. So it would be great if it continues to come down from there. We'll just have to keep an eye on it. COVID emergency department visits in the orange are more or less leveling off. Hopefully they'll come back down some more. RSV emergency department visits do look to be heading down. And now taking a look at hospitalization rates, flu hospitalizations do still look to be heading up as of February 8th, not nearly as steeply as they were before. So you can see that before that blue line was going up a lot more sharply. Now it's still going up and not nearly as sharply. Both COVID and RSV hospitalization rates are so slowly coming down. And here we're taking a look at trends in viral respiratory deaths. And all the way over to the far right, we can see February, the week of ending February 1st, where the blue, which is influenza, is representing more deaths than COVID, which is in the orange. And that was also the case the week before that. So for the weeks ending January 25th and February 1st, for the first time since the onset of the SARS-CoV-2 pandemic, there were more viral respiratory deaths from flu than from COVID. And so this is likely due to two main things. One is that we do seem to be doing better regarding COVID deaths, and the other is that we are having a rough flu season. So let's walk through both of these a little bit. So taking a look at COVID deaths, we're seeing fewer deaths this winter from COVID than we saw last winter. So as always, there are no guarantees about where things will head next, but it's possible that we've reached our peak with COVID deaths this winter because we can see here that they're now coming down. So the last 4 bars or so are definitely coming down week over week. Now we know that the gray bars are preliminary. They can certainly go up further, but they generally don't increase by leaps and bounds. So we do expect them to go up some, but it is possible that we are heading down from our peak of deaths this winter. And of course, going forward, there's also no guarantees. Things can change. We could have a new variant that could make things worse. So we don't want to get overconfident. We just want to keep all of these things in mind. But by way of comparison, our peak of COVID deaths last winter was the week ending January 13th, when there were 2,584 deaths. So if we did indeed reach the peak of this winter for the week ending January 11th, 2025, First off, I think that'll be pretty interesting because that is very close to exactly 1 year from our last winter peak of COVID deaths, which was January 13th, 2024. And this year in 2025, for that week, we saw 983 deaths as opposed to 2,584 deaths that corresponding week last year. So that is less than half. It's actually a little less than 40%. So hopefully this really is the peak for the winter deaths and we'll continue to head down from here. That does remain to be seen. And hopefully every year it just keeps coming down further as we've kind of seen for the last few years. But let's also keep in mind that if our patterns from the last few years hold, we can expect a summer surge. Of course, we've had increases in cases other times of year, but again, by comparison to last year, after reaching that peak in deaths that I spoke of, the week of January 13th, 2024, things continued to come down from there all the way until June, when they then headed up pretty significantly until they peaked at the end of August. So no 2 years have been quite the same so far in this pandemic, but we do seem to be settling into a bit more of a pattern. I'm definitely not saying it's a great pattern because this is still quite a lot of people dying every single week, but some pattern is better than no pattern. One of the things we'll be looking out for, in addition to looking for those high points, is we want to be looking out for the low points as well. So are the low points getting any lower? And this is something we'll continue to revisit. But in general, the low points do seem to be coming down overall when we're looking year over year, which is a good thing. But to put it in perspective, the lowest we've ever seen COVID deaths was actually last spring, when we were still seeing deaths in the 300s to 400s every single week. So that is still an enormous burden, especially when you start to look across the entire year. But as it relates to this most serious, most severe outcome, death from SARS-CoV-2, I think we can say that things are improving and they seem to be improving year over year, and hopefully they will continue to do so. But we do know that this is only about deaths from the acute SARS-CoV-2 infection. This does not include deaths from post-COVID issues we're seeing. This does not include deaths from post-COVID increase of heart attacks and strokes. This does not at all take into account the burden of post-COVID chronic conditions, including long COVID. So this is just one terrible outcome, but of course we want to see it improve. And it is so far. Now, with all of that being said, we do know that there's still quite a lot of SARS-CoV-2 circulating around in our environment. Nationally, wastewater bioactivity is considered high overall and is the highest and also increasing the most significantly in the Midwest territory. It's also considered high, although leveling off in the South, and in the West, as well as the Northeast, it is in the moderate range. And if this is something you're interested in looking into in your area, I'd encourage you to check out one of the resources in the post to see what is going on near you, if that information is available, because it does vary quite significantly depending on where you are. So I mentioned earlier that we're having a rough flu season. Last week, we talked in some detail about school closures across the United States as a result of this bad flu season. And now and I also talked about how we need more transparency and about why these decisions and how these decisions are being made around school closures and how that might compare to how we're thinking about other infectious issues. So if you're interested in that, you can check out last week's briefing. And today we'll just go into a little bit more detail about how the impact of flu in the United States is looking so far this season. So first, for a United States influenza snapshot, so far this season through February 8th, there have been about 29 million flu illnesses, 340,000 flu hospitalizations, and 16,000 flu deaths, including 68 pediatric deaths. And in order to put this into some perspective, I'm going to share a graph that I really haven't shown very often on the briefing before because it looks a little chaotic if you're not used to looking at it. But I'm going to show this by sharing my screen so that we can walk through it. What this is showing is laboratory confirmed flu hospitalizations, and each colored line here represents a different year. So this is a lot. So what I'll do first is clear them all out and just show us this year, 24-25 season. So this is as far as we've got so far this season. We obviously don't know what's going to happen between here and here. We don't know if we're going to go down and come back up or what's going to happen, but this is what we've got going on so far. And so I'll kind of add back prior years. So last year, 23-24, we can see that first off, we peaked a little earlier, but we didn't even come close to what we're already experiencing this year in terms of influenza hospitalizations. And looking at 22-23, peaked even earlier, about the same place as the 23-24 season, but then came back down. The 21-22 season, well, we know that that one was when we were taking a lot of precautions around COVID. Those were really effective for flu. So we can see that we had considerably less hospitalizations for influenza. And then the year before the pandemic, 19-20, once again, the peaks were much, much lower than what we're seeing so far this year. So a high burden of influenza hospitalizations as well as influenza deaths this season. And we really don't have a great line of sight as to why this is occurring. And that is really because of what's been going on with the public health communications freeze. And that includes our impending withdrawal from the World Health Organization. So flu is definitely one of those things where collaborating worldwide has really been critical, not only to understanding what is going on, but also to predicting what's going on, because remember, we have flu affecting the different hemispheres at different times. So we can prepare better, also to develop the appropriate flu vaccines each season. And we would all like to understand what's going on at any point in time, especially when we're having a more severe flu season like we are having right now. So normally here in the United States, we would expect to have direct communication from CDC by now about the situation. So even though I know that I have expressed that I'm glad that some of the regular surveillance tools that I just showed and that I've been showing every week are being updated, by itself, it's just not enough. So normally we would have been getting more information, maybe some MMWR reports coming out of CDC about what's going on in a particular area or a particular hospital network, for example, or a particular age group, for example. We would expect to have a HUN or a health action alert, a health action network, kind of these alerts that they share with healthcare providers. And these I've shown here on the briefing many times over the years, because these health action alerts are a key way that CDC communicates with healthcare providers. So despite the fact that we're obviously in the middle of a very bad flu season, we're flying a little bit blind as to whether there are specific preparations we need to be making, any specific guidance for healthcare providers that we would normally expect. So some of the questions I might have about why we are experiencing a more serious flu season, why we're having more flu hospitalizations and more flu deaths, for example, would be, is this because we're dealing with a particularly bad strain of flu? So maybe one that makes people sicker, or maybe one that is more contagious? Or do we think that it's just because of lower vaccination rates? And more data will be needed to answer some of these questions, and these data and this information just has not been forthcoming. Or do we think maybe it's because of more co-infection for some reason, such as flu plus COVID or flu plus RSV, or even flu A plus flu B? We've seen some of these things in our practice, but that's anecdotal, and we're sharing information with other organizations, and we're sharing data locally, but that's not the same as big data that we rely on in order to do more planning and preparation. So we're kind of increasingly relying on local entities like our county public health departments, our local hospital networks, our state public health departments, which each are doing very different things, reporting into very different systems, and even following different guidance depending on where you are. So this is all very concerning because it's leading to less information that should be really informing our planning. And this is something that can be deadly. For example, it takes planning to ensure that we have enough antiviral medication. It takes coordination to make sure we have enough hospital beds. And of course, these things are happening to varying degrees in different areas, but there's a reason why there's generally a high degree of collaboration between public health and the healthcare delivery system around things like flu, because there's a big connection between how we're doing on a public health level and how we are doing in terms of our healthcare delivery system's ability to respond. And we saw just recently with SARS-CoV-2 how our healthcare delivery system can be overwhelmed if we're not properly prepared. And unfortunately, a lot of the data systems and communication that we had before the pandemic, others that we developed during the pandemic, are all kind of at risk at the moment because of decisions that are being made right now about not communicating and not collaborating. And as I also already kind of alluded to, there's a reason why there's so much global coordination as it relates to flu. So this brings me to the next concern about our lack of data transparency, and that is that, as you know, we've signaled that we are withdrawing from the World Health Organization. And it unfortunately is already the case that we have stopped sharing our flu data in the same ways that we have shared it before. We are not sharing our flu data through some important systems that we normally have in the past. I linked an interesting press briefing from World Health Organization where you can hear Director General Tedros and also Maria Van Kerkhove from World Health Organization, who are basically explaining that US CDC is not reporting influenza data through the usual platforms like FluNet and FluID, where the US has been providing information for years. They also talk about how we're not sharing information, including some of the technical exchanges that happen between scientists, and that the US is not participating in those, including supporting with the H5N1 situation that we are brewing over here in the United States. So this is all having an impact on us here in the US. It's having an impact globally, and flu is just one part of that. And the WHO officials were very clear in complimenting the abilities, the technical capacity, the science being done here in the United States, and how they really are wanting to be able to communicate and collaborate. But it is clear that much of that is not able to occur at this time. So if you want to hear more about the impact of this, as well as other decisions that have been made by the United States, like stopping supporting HIV treatment across the world, you can check the link to that video in the post. So certainly a sad state of affairs and a potentially dangerous state of affairs as it relates to public health. And it's unclear what the end game is here, what the reasons are here, and what is going to be put in place here. So we're just continuing to do what we can to connect with colleagues, to connect locally, to identify whatever patterns we possibly can. And hopefully some of these vital avenues for communication, like the health alert networks, will resume as soon as possible. And so we do have a measles outbreak to report. By now, you've probably seen some of the headlines about a measles outbreak in West Texas. And so this is a very significant outbreak. It's been going on for the last few weeks. So far, there have been 48 cases identified. Out of those, 13 have been hospitalized. So that's nearly 30% of the cases that had to be hospitalized, which is, again, significant. Just want to say here that CDC has not issued any report on this. No health action alert, no MMWR report. The CDC measles page has not been updated since February 6th. So it really doesn't really even include information about this very significant outbreak. So we are primarily relying upon county and state departments of health for our information. And what we can see here, and this is from the Texas Department of State Health Services, is that this particular outbreak so far is mostly affecting children and adolescents. So 42 out of the 48 cases so far are among those 17 and under. And we know that this can have devastating consequences. We know that this can have long-term consequences for these children. This particular outbreak seems to be happening in a community that has high rates of vaccine exemptions and low rates of vaccination overall. But as we've gone over a few times here on the briefing, this county is not alone. This is by no means the only one where we have high rates of exemption and increasing rates of exemption and low overall vaccination rates. So there are many pockets where the vaccination rate has dipped well below the threshold where it needs to be in order to prevent these kind of outbreaks. So this is, again, another very sad state of affairs and us really moving in the wrong direction. And unfortunately, this is likely just a sign of things to come based upon what we are seeing with vaccination rates in different areas across the country. Of course, there are states with exceptional vaccination rates like California and New York, but there are others who have very, very low vaccination rates, and particularly in particular communities or counties or school districts. And this is really important if you're in those places and if you're in particular groups that may be more vulnerable. So I'll get into that more in a second. But this particular outbreak is ongoing. It already seems to have caused cases in neighboring New Mexico. It's very much still ongoing. So quite a lot of testing, a lot of isolating, quarantining, preventive measures that are being taken. And we'll just have to see how long it will be before they're able to get it under control. Because we know that measles is basically, it's known as the most contagious thing out there. So one person can spread it to many susceptible people in a very short period of time. So even if a positive person leaves the room, they can leave behind infectious particles that last for hours, and that can infect susceptible people. So first, I'll just say that if you have received the 2-dose measles vaccine series, or if you've contracted measles earlier in your life and survived it, then for the most part, you should be well protected. So the vaccine, like any vaccine, like anything, is definitely not perfect, but it is about 97% effective at preventing measles when you get that 2-dose series. So that still does leave 3% of people who, for whatever reason, didn't mount an adequate response or are not protected after vaccination. But 97% is excellent, and it is sufficient if enough people in the population have been vaccinated. Now, people who are not protected from measles, either by having been infected before or having had the vaccine, 90% of them will get measles if they get exposed. So if they come near someone who is contagious and you don't have prior protection, your chances of getting measles if exposed is incredibly high, 90%. So this is not a chance most of us would want to take. Another issue is that for the most part, children under 1 year of age are not old enough to have started the vaccine series yet. So this can be life-threatening for these babies and can have long-term consequences for those who survive. So in these areas with outbreaks, what's happening is that they're having to go out and do quite a lot of investigation, isolate people who are positive, quarantine people who are exposed, offer vaccination, offer post-exposure prophylaxis in order to protect people from developing measles. So now we have a situation where they're going to have to be more aggressive about trying to vaccinate children. They're even going to want to start vaccination at a younger age that isn't even the normal age that we would start the vaccine, because it's not the optimal age for mounting a good response, but desperate times call for desperate measures, and it is better than nothing. So what will happen is that what's being recommended in these impacted areas is that if you are a baby underneath that 12-month range, that you still go ahead and get a dose, but then you still need the 2 doses. So now you are getting 3 vaccines instead of 2. So this seems to be very counterintuitive when people are trying to just avoid the vaccine altogether. But ultimately, I think when most people are faced with this imminent disaster situation, they will then go ahead and do what's necessary. But we'd really rather if we didn't have to wait until it's after the fact or wait until it's potentially too late, because this can be devastating and have lifelong consequences. So, but this is just what we have to do if we want to protect those babies from all the people who are not protected and who are making themselves vulnerable, but also everyone or others around them vulnerable. So because we've enjoyed a relatively long period of time here in the United States without really seeing much measles, most of us have not really experienced what it can lead to. So this is not chickenpox. And I'm not trying to minimize chickenpox, but this is not chickenpox. This is something that we absolutely do not want to be exposed to without being protected by a vaccine. And there's a number of reasons for that. But as we've seen so far in this outbreak, a significant portion of measles patients do need to be hospitalized. And up to 3 out of every 1,000 of them will die. So about 1 in every 350 people who get measles will die. And this is usually from respiratory complications or neurologic complications. So a very unpleasant situation, tragic situation. And about 1 in every 1,000 who get measles will develop swelling of the brain or encephalitis. This can lead to disabilities. This can lead to deafness. It can lead to seizures. There are also some very terrible potential later complications I won't get into today. But something I did want to touch on is that measles is actually known to wipe out some of our immune system. And this is something that can be prevented with the vaccine. So the vaccine not only prevents you from just getting the measles, it prevents you from having what can be a much longer term impact of having a measles infection, which is that it can actually wipe out parts of your immune system. So this is a pretty frightening phenomena, but it's also really fascinating discovery. And I do think it's something that should be understood more broadly because increasingly, unfortunately, people are making a decision to not vaccinate their children. And if they're going to make that decision, I think it's important that they understand the full gravity of that decision, especially if this trend keeps going. Unvaccinated people will no longer be able to just benefit from the fact that everyone around them is vaccinated, because that's essentially what has happened for the most part so far. Because we've had high vaccination rates, the occasional unvaccinated family or child has really been able to benefit from the fact that everyone else around them is vaccinated. But because those vaccination rates are dropping in some areas, they will no longer be able to enjoy that protection as maybe they have been able to in years past. So the bottom line is that we have some very good evidence that measles causes what is being termed immune amnesia. And what that means is that even after, let's say you get the measles and let's say you get through whatever those consequences may have been in the short term, but then for years after that, there are parts of the immune system that you had previously developed that are more or less wiped out. So now you're even more susceptible to other infections that you otherwise would have been immune to or had some protection against. So you would have built up some antibodies to some previous infection, and those literally get wiped out. So it's like you never saw it at all. So things you developed antibodies to before are actually getting wiped out. So there are a couple of important papers about this. Dr. Minna is the researcher who I've actually quoted here a number of times regarding all of his amazing work on rapid COVID testing. But the work he's done on measles long before the pandemic is really fascinating. One of the studies is population-based and led to additional clues that kind of put them on the trail of what to look at next. And then they were able to do a study that really provides a detailed look at what happens to the immune cells of patients who have survived measles. And basically it shows what I described, that all those antibodies that you might have gotten before get reduced. So there's fewer antibodies and less diversity among those antibodies in people who've had measles compared to those who have not. And so I've linked a couple of articles in the post. And because it gets a little complicated, I also linked what I think is a very well-written article from the Medical Republic from 2020 called The Great Measles Immunity Heist. So I think it's well done and really accessible. So if you don't want to dive into the journal articles, I think that magazine article is a great place to start. So the most important thing we can do right now is make sure that you and your loved ones are up to date with the measles, mumps, rubella vaccine, or the measles, mumps, rubella with varicella vaccine that's also available. Typically, as I mentioned, the first dose of the MMR vaccine is between 12 and 15 months of age, and the second dose is between 4 and 6 years of age. Now, this year's childhood vaccination schedule, or the immunization schedule, has been updated, and there are some specific updates related to MMR. So to show you those, I will now share my screen. This is the child and adolescent immunization schedule by age, and anyone who takes care of kids or has kids has probably seen something that looks like this, where there's a lot of different colors on it, and the age across the top here, and the list of the different vaccinations that are needed at the different time frames. So in this case, we're wanting to look at MMR, and we can see that the first dose is here between the 12 and 15 months. But we now have this area that says C notes for our 6 to 9 month olds. And so this is what I wanted to call our attention to today. So taking a look at that screen, you can see measles, mumps, and rubella. And we're going to look right now at special situations. That's what I wanted to call your attention to. And we can see that international travel has some pretty specific guidelines about what to do, because normally your baby under 12 months would not have an MMR dose, but what it is stating here is that if there's going to be international travel, that infants age 6 to 11 months should go ahead and get a dose of the MMR before departure. And then you're going to revaccinate with the whole 2-dose series at 12 to 15 months. And so this is significant because it is, first of all, about protecting children who would otherwise be unprotected with the 1 dose before departure. But it is also addressing the reason why we don't normally give this that young, which is that we are concerned that the response will not be as robust when we're giving it this young as compared to 12 to 15 months old. So you're going to need to get the 2-dose series anyway, beginning at 12 to 15 months. And just a quick refresher on measles symptoms here. So there's the early warning signs: high fever, cough, runny nose, red watery eyes, loss of appetite, and fatigue. So somewhat nonspecific, but if you're not protected from measles and you're anywhere around where there's been exposure, and you do have to kind of stay alert to see where that might be. Usually there will be press conferences, news conferences, and things like that to let you know. So stay alert around that. But then a few days after the fever is when you get that typical rash on the face and body, red spots, tiny bumps, and some itchiness. So these are just some things to be aware of, but I think the most important thing to reiterate is really the bottom line here is to protect yourself, protect your loved ones with the 2-dose series of MMR. If you're not sure if you're covered, check with your primary care doctor. If you don't have one, please get one, and stay up to date on all of your preventive measures. If you're someone who cannot take MMR, if you're someone who's immunocompromised, and have some contraindication to MMR, I think it's really, really important that you're aware of what's going on in the region that you're in. And hopefully you're in an area with high vaccination coverage, but this is sadly something I don't have a great solution for, but it is something to be aware of, because not everyone can be protected. And this is part of the reason why, if we care about not only ourselves, our loved ones, our community, then part of it is getting to that point where we are achieving community immunity, and that means a high vaccination threshold. And if not, we are simply leaving people behind. We are leaving people vulnerable, and that includes the youngest people in our society who we would really want to have a chance at a full life without all of these terrible complications that are really almost completely preventable. So if you're not sure if you're protected, please check in with your primary care doctor. If you don't have one, please get one. Know how to reach them before you need them. Stay up to date on all those preventative screenings. Also, vaccines. That includes flu vaccine. It's certainly not too late to get this season's flu vaccine, where it's not, the flu season is not nearly over yet. Remember, if you don't feel well, particularly if you're someone who should be treated, please get tested right away to see if you have flu or COVID, so that we can get you started on those antivirals. The sooner, the better. And also so that you know what you have and you can isolate yourself away from others and prevent you spreading what you've got to others. For a high quality filtration mask when you are mixing around others. And you can also do pre-event testing, test yourself before, especially before you go around others without a mask on, because we don't want to get others sick and have them end up in some of these statistics that we've been going over. They are very real, and each of those numbers and each of those statistics represents human beings and loved ones and family members. And so we all want to do our part to prevent that. And remember to eat a balanced diet, quit smoking, limit alcohol intake, avoid sugars and sugary drinks and processed foods and artificial ingredients. If you don't feel well, make sure to get your rest. Otherwise, get some physical activity, get some fresh air, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. We will be taking next week off, and we'll see you back on Tuesday, March 4th at 10 a.m. See you then.